Hello, everyone, and it's Thursday, so it is time for something to talk about live. Thank you so much for joining us. I hope everybody had a nice Thanksgiving if they were able to celebrate with family and friends. And just like always, I'm going to bring in Jean Marie Nevada to host today's conversation.
Hey, Jamie.
Hi, Jean Marie. How are you?
I'm good, although I am continuing to work on my mission of getting through a week without mashed potatoes, which has not been easy.
I mean, that sounds like a terrible week, though, so I don't
It
even know
really
why I'm
is.
crying
It's a sad week. Last week was much, much better with mashed
with
potatoes.
mashed potatoes. I like it. My favorite dish this year for Thanksgiving was with sweet potatoes, so we're all the
See?
same wavelength.
It's all about our carbs. We are a carb-based team, cats and carbs.
That's
But we have a great conversation today and an important one. So thank you for getting us started, Jamie, and I will maybe see you later.
all right.
Hey, everybody. My name is Jean Marie Nevada. I'm the Director of Learning and Inclusion at pflagnation.al. My pronouns are she and ella. Every single week, we get together to talk about something related to LGBTQ equality and inclusion. And this week, as we are on December 1st, is World AIDS Day. So the commemoration started quite a while ago to really commemorate both the people that we've lost, but also the work that is happening towards ending the HIV epidemic. And just to kind of remind people of where we are, depending on what generation you come from, you probably see this a little bit differently. I am of the generation who grew up in the HIV and AIDS epidemic. So it's something that feels very personal often. But right now, we know that HIV has claimed about 40 million lives globally so far. In just last year, about 650,000 people died and 1.5 million were infected, and those are global numbers. And while treatments have become incredibly effective, people can live with HIV, live normal lives. Those treatments often are they're based on if you can get access to them, if you have resources to pay for them, and even if you can get to them. So we still have a lot of work to do. So if you are joining us to read this week's article, we picked something from the Bay Area Reporter, and the title is World AIDS Day Draws Attention to the Epidemic. It is a little bit focused on what San Francisco residents are doing this year. But we want to have a much bigger conversation about what is happening. And for that, I want to welcome to the show the President and Chief Executive Officer of the International Association of Providers of AIDS Care, Dr. José M. Zuniga.
Hi there.
Welcome. Thank you so much for joining us on what I know is probably the very busiest of weeks for you.
Pleasure to be here.
So before we get started, for people who do not know about your organization, can you tell people a little bit about when it was founded? It's several decades old at this point. When it was founded, what you do, what some of those key programs are.
Sure. We were founded in 1985, which makes us the oldest medical association dedicated to the HIV response. We represent more than 30,000 clinicians worldwide. And although we advance the traditional mission of a medical association, so continuing education, normative guidance, et cetera, we do much more, including in our capacity as the core technical partner of the Fast Track Cities initiative, through which we're assisting more than 450 cities around the world to end their urban HIV epidemics by 2030. If folks want to learn more about our association, you can visit www.iapac.org.
And thank you. And, actually, I'm going to jump to a question I wanted to ask a little bit later, but because you mentioned it, I was reading all about the Fast Track Cities network. There are now more than 400 cities participating now. Could you tell people a little bit more about what the network's goals are? Because it wasn't just about end HIV. It actually was much more broad than that. And I found it fascinating.
Sure. Fast Track Cities was founded so that cities and municipalities of all sizes and from all over the world could take action to end AIDS as a public health threat by 2030. But as you mentioned, the initiative has evolved since it was launched on World AIDS Day 2014 to include a broad social transformation agenda that includes addressing stigma and discrimination, as well as health and inequalities and inequities that are exacerbating the situation for so many people around the world. So we're at 450 and counting cities and municipalities that have joined us, and they are doing amazing work. In the US, we have 32 fast track cities, so a critical mass of them, and we believe we can have an impact on the national HIV epidemic through the work that these cities are doing.
And I think it's really fascinating. And I actually had a question about that. So the effort does center on HIV, but when I was reading about the network, you did mention that it got broader, and diseases like tuberculosis and hepatitis are both included in this. Why are these issues, or why are these diseases being grouped together as part of this work? What is the reasoning behind that?
We wanted to provide the Fast Track cities a value-added proposition in that, although it is critically important in our mission to end AIDS as a public health threat by 2030, we could, through the work that these cities are doing in strengthening community links, in working with the health departments around data-driven, equity-based activities, also end a tuberculosis epidemic and eliminate viral hepatitis, specifically HPV and HCV. And so far, the proof of concept has been very positive. In fact, this has really moved quite a number of issues, including around syndemic conditions such as mental health conditions, which are pervasive, notably exacerbated after the COVID-19 pandemic.
Absolutely, absolutely. Thank you for explaining that, because I as I was reading about it, I thought, I think I'm understanding why they get grouped together, because we are talking about access, eliminating inequities and stigma. But I really appreciated that explanation. So the theme for this year's World AIDS Day is Equalize, which really did center the need to eliminate stigma, as well as provide preventative and palliative care, especially in marginalized communities. But one of the stats from the UN that got my attention was that only 52% of children who have HIV are actually getting the proper treatment now. So when we hear, in the context of the conversations about HIV and AIDS, conversations about marginalized communities, right now, as you look at this, who falls into that category?
There's a broad range of people who have traditionally and who are historically been marginalized, been stigmatized, and left behind in the HIV response. And they include sexual minorities, sex workers, incarcerated individuals, but also women and young girls, and as you noted, children. Regrettably, we stand in a position now where a large percentage of children living with HIV have no access to the very treatment that is keeping adults alive and productive members of society. And so this social marginalization that has been persistent throughout the HIV pandemic is one that UNH has certainly called out in selecting Equalize as the theme for this year's World AIDS Day. Equality in relation to health, but also broadly social equality, is the only way that we believe we can end the HIV epidemic. We have the tools, antiretroviral therapy, pre-exposure prophylaxis, but without equitable access to these treatments, we cannot end the epidemic.
You know, as you were speaking about this, I was thinking back to the 90s, which I'm about to date myself on this, but I remember I had this pin that was from ACT UP, and it said, "Women get AIDS." And it seemed as though that was a very revolutionary thing to say at the time. And it's interesting that we're still having that conversation now, that populations who a lot of people assume don't are still suffering. When we talk about these marginalized communities, are you seeing sort of similar challenges both inside of the US and then as we look at it on a global scale, or are some places doing a better job at addressing this than others?
There are many parallels between the inequality and social marginalization that we're seeing abroad and in the US. Of course, there's nuance with respect to how it manifests. Here in the US, of course, we have significant issues in relation to racism, and that impact on the ability for people to access and utilize HIV and other health services is quite significant, and contributes to the number of new HIV infections we continue to see here in the US, one of the most affluent countries in the world, where you would assume that epidemic control would have happened by now. It has not, because people are not in a position to access services, and in many respects they are disencouraged as a result of the way in which they are treated and marginalized from seeking these services.
And actually that brings me to the next question that I wanted to ask you, which is about stigma. It's, if you read anything about AIDS, HIV advocacy right now, about the work that is happening, you cannot read something without people talking about the need to continue addressing stigma. Could you talk a little bit more in depth between this connection between certain diseases, and HIV is certainly not the only one, being stigmatized, and how it feeds into people then not getting the care or even the diagnosis that they need.
Regrettably, this many decades into the HIV pandemic, stigma is still perpetrated against people living with and affected by HIV, even HIV negative individuals who fall within key populations or vulnerable populations to HIV acquisition are stigmatized. The impact of that stigma really is defined by the fact that, for example, last year we had 1.5 million new HIV infections globally, and it's manifested in the 650,000 AIDS-related deaths that occurred as well. The stigma is as insidious to me as the human immunodeficiency virus, and it's something that we are adamantly opposed to, obviously, including its perpetuation within healthcare settings and certainly within IAPAC's mission to ensure that when a person living with HIV or affected by HIV enters a health facility anywhere in the world, they are not confronted with the stigma and discrimination that will make them turn on their heel and walk out the door without accessing life-saving treatment or prevention options.
And in some places, we're still talking about criminalization of people who have HIV and AIDS. Is that also part of what we are grappling with as we look at this globally?
We are grappling with the repercussions of criminalization, not just of exposure or not or transmission, but also criminalization of key populations, behaviors of transgender individuals, sex workers, people who use drugs. This only helps to fuel the epidemic in that it presents a barrier for people to access and utilize health services, but is also a human rights violation. In relation to criminalization, of course, many of these laws have not been revised in quite a number of years, or even reviewed in quite a number of years. We've made such significant progress in HIV treatment, for example, that today undetectable equals untransmissible, or U equals U. That message has not really resonated within the halls of justice, and we need to advocate for these laws to be changed, because in essence, we're basing our laws on 19th century, 20th century science when we're clearly in the 21st century with the tools at our disposal to ensure that people can live long and productive lives.
It's as you're saying this, I'm thinking about, I live in Palm Springs, California, and I live not far from what used to be Desert AIDS Project. Now it's just DAP. And when you're going past, they have a billboard, the digital billboard, and U equals U is one of the messages that comes up over and over again. And I think it is so fascinating. And I wonder how many people, as they're passing it, who don't know about it, might start asking questions. And I think it's so important that we're seeing those messages. But I've also seen some other programs going on. For example, I remember going to the doctor recently, and they had asked me if I had ever had an HIV test. And I said I actually hadn't, because I wasn't in any particular group that would have triggered somebody to do it. And they said, well, we're testing everybody. And I did my test, of course. Is it programs like that are also shifting people's perceptions, that this is an everyone conversation and not just for specific populations?
There are quite a number of innovations that have been implemented in the HIV testing space, including HIV self-tests at home, opt-out testing in emergency rooms and other settings. It's critically important that we diagnose people early so that they get on treatment if they're positive, or if they're negative, that they can access prevention services if they feel they are vulnerable to HIV acquisition. So the testing component is so critical, and it's the first step in what's called the 95-95-95 targets that UNAIDS set several years ago. 95% of people living with HIV knowing their status, 95% of people who know their status on antiretroviral therapy, and 95% of those achieving viral suppression, through which you also achieve U equals U.
Right.
We can't get to U equals U if we have a vast number of people undiagnosed and presenting with late-stage disease in our medical centers.
Yeah, I just thought it was so fascinating. It was, and they explained it to me. They said we're testing giving everybody an option to get tested. And I thought, what an interesting thing that it wasn't we're asking you this question because of something you mentioned about your background, but this is something that we're all talking about. So for people who are advocates for inclusive care and good care, what should someone do when they encounter stigma around this? When they're with a healthcare provider, how should they have a conversation when they feel like something has been said or done, particularly by a healthcare provider, that maybe isn't? What should that conversation sound like? Because I think a lot of us would be stunned if we actually heard it.
We all have a choice, obviously, when we're confronted with stigma or discrimination or bad treatment by a healthcare provider. We can simply walk out and find another provider. That's our choice. But I would argue that we each have an opportunity to educate providers, particularly as HIV care shifts from specialists to primary care providers, to educate them and sensitize them to the reality of HIV in 2022. The fact that if you place people on antiretroviral therapy and they achieve viral suppression, they cannot transmit HIV to their sexual partners. And the fact that we have pre-exposure prophylaxis or PrEP that reduces acquisition of HIV by an HIV negative person 98%. Very effective tools at our disposal. But there's also, I think, a need to educate providers on the importance of the human rights dimension of the HIV response, that we are all the same people and should be treated with dignity. Our well-being and our ability to live lives free of stigma and discrimination should be forefront in the mind of every healthcare provider who is an oath to first do no harm.
Yeah, thank you for saying that, because I do think there are so many of those conversations we can have when we are, interacting in healthcare settings, but I think it feels very intimidating sometimes. But it's only when you initiate it that anything is going to change. So one of the intersections, and I certainly saw this a lot in the work that your organization is doing, and in a lot of other places with HIV and AIDS, is that of racism. So in 2021, the CDC declared racism an actual public health crisis. And we've seen how racism can hamper responses to public health situations. We certainly saw it during COVID. How could you, for people, again, who might be a little bit newer to this part of the conversation, can you talk about how racism actually does have an impact around testing and treatment for HIV?
Sure. Well, we're talking about decades of structural and systemic racism here in the U.S. And it's certainly not endemic to the U.S. We see it in South Africa. We see it in Europe, other parts of the world. But its effect is quite significant in that it reduces a person to their color or a certain personal characteristic that devalues them. And in that sense, when a person is devalued, perhaps they don't see the relevance of seeking healthcare or of following safer sex advice from a provider or for a community-based group. They don't identify themselves as part of society as a whole, and therefore they fall through the cracks in our system, not just our healthcare system, but our social support system. Yeah. We also see it obviously in the need for criminal reform and the fact that so many Black and brown people are incarcerated in the US speaks to a criminal justice system that is skewed against them. This all feeds into the HIV epidemic and in creating the environment where people acquire HIV, don't get tested, and ultimately they progress to AIDS and die. The fact that people are still dying of AIDS-related complications in the US or anywhere in the world is a public health failure and almost criminal itself, if you think about it.
I absolutely agree with you on that one. So what are some of the effective ways that you are seeing that this is being addressed, particularly sort of in the HIV and AIDS realm, sort of breaking down also the racial stigma and the racial biases that we're dealing with?
So a couple of things. Number one, we're talking about it. And, it's said to talk is cheap, and I'll get to the other bit we're doing, but we're actually talking about it and bringing folks together to understand what a dynamic issue this is and how complex it is to address, both at the individual level and the institutional level. But as important, we are documenting best practices across communities for how we tear down these barriers that are constructed from structural and systemic racism, longstanding. In that way, we're sharing these best practices across communities worldwide so that they can implement similar activities and ensure that one person at a time, if it has to be, we are making sure that they feel valued and that they access the HIV and other health services that they deserve and which will keep them alive and healthy.
I'm smiling so much when you say this because I think it's so incredible when a platform and a space is created for the exchange of that information. We don't need to keep reinventing the wheel. Someone's got it down. But I think when we have those spaces, when those spaces are created and that sharing happens, that's when you have the opportunity to say, well, what worked here? Let's adapt it here and let's keep going. But we know that we have a promising plan. And so I'm so grateful for people who are working on creating a platform and a place to exchange that information. So it's definitely been a challenging few years for everyone. And I think in public health, it has been especially difficult and ugly. So in addition to the work that was already being done on diseases like HIV, providers were faced with COVID, monkeypox, and even the resurgence of things we thought were mostly gone, like polio. Are there parallels between some of these outbreaks that we've seen, particularly COVID? I know that a lot of people said it felt so much like HIV in the beginning. Are there some parallels, but are there places where this has sharply differed in your view?
I have to admit the health workforce is exhausted, and my hat's off not just to IAPAC's clinician members, but to health workers in every field. I mean, the colliding pandemics of COVID-19 and HIV created such stress points on our health systems, but we also saw incredible resilience across the board and the ability to ensure continuity of HIV and other health services thanks to very brave, courageous, and dedicated health workers. The parallels are significant, particularly when you talk about a stigmatizing virus such as monkeypox. In this instance, we saw some of the same stigma or stigmatizing words and graphics used by forces of, I would say, evil to describe people who were infected with monkeypox virus. We also saw racial undertones in relation to reporting on the outbreak here in the US and Europe. And so in that respect, there are parallels. But sadly, both the COVID-19 and monkeypox outbreaks also revealed some weaknesses in our ability to respond to new and novel diseases. And I think that we have an opportunity, hopefully at this point, to reevaluate where we stand and to take up the innovations that were implemented during times of real hardship, so that in that sense, we are prepared for the next outbreak of whatever virus comes along, because it is certain that that will happen.
Yeah. Do you think that the focus that had to happen to switch over to the energy and I think focus and even funding to issues like COVID took any of the HIV work that was happening off track? Because we have talked about you and AIDS, and they said basically unless efforts are doubled on HIV right now, we're going to hit that worst case scenario of 7.7 million deaths. So do we need to refocus now?
We do need to refocus, but as important, we need to think through how we ensure that the HIV response is viewed as an asset to the public health world as a whole. And I think that COVID-19 certainly was an opportunity for us to show that the HIV platform could be effectively leveraged to ensure that the worst of what we feared in relation to COVID-19 did not materialize. Now, what that took was a repurposing of the HIV health workforce in many respects, a repurposing of monies allocated towards the HIV response, and a lot of time. Just distraction, if you will, and I hate to use that word, in connection with a disease that has killed so many millions,
Yes.
COVID-19. But there's a need to both refocus and regain momentum so that we can get to where we need to be with the tools we have at our disposal. If we don't do that quickly, we will lose such significant ground that we've been able to achieve so much over the last several years. It makes me fearful.
Thank you for saying that, because I think as things unfolded, so many of us said we're seeing parallels in how we have responded, and so much of it looks like it came out of HIV and AIDS activism. So, HIV and AIDS obviously haven't disappeared, but for many, and especially for people in the U.S., many people, not everyone, it has become a disease that you live with. It is not a death sentence as it was in the beginning. But because of that, the flip side is sometimes we're not having these conversations the way we did in a time of much bigger crisis, which I'm glad that we are not in. Do you have concerns at this lack of attention, the fact that sometimes the only time people are having this conversation is December 1st? Do you find this lack of attention on the disease risky?
I think that we have seen a significant decrease in attention paid to HIV by the media, by our communities at large. And thankfully, we have days like World AIDS Day where we can draw attention to the great progress that's been made and the challenges we face. But I will say that although we are not experiencing the great crisis that we faced in the early days of the pandemic, it's a crisis for those who lack access to HIV and other health services. And it certainly is a crisis for the 650,000 people who died last year of AIDS-related complications, their families and loved ones who were left behind for no good reason other than people lacked access to life-saving medications. And so my hope is that we do as great a job as we can on World AIDS Day to ensure that people hear our message, but try to draw out a year-long dialogue across all of the various HIV awareness days, including a new one that we launched. It'll be July 21st of next year, Zero HIV Stigma Day, in honor of the late South African activist Prudence Mabela, really an attempt to ensure that people understand the stigma perpetrated against people living with and affected by HIV cannot stand, and we have an opportunity to end it in all its forms.
Thank you. And thank you for sharing that with us. So one last question for you. We like to leave people with something to do. You said that keeping this dialogue going year round is so important. Can you suggest to sort of the everyday advocates out there, of which PFLAG has many, a couple of ways that they can keep this conversation going when it's not December 1st, when it's not July 21st?
Talk to your friends, talk to your neighbors, talk to your coworkers about HIV and the importance of ending it in our lifetime. And as important, support your local community-based organizations and national organizations, because we are living in a time of significant financial constraint, and the ability for nonprofits particularly to advance their mission, as well-intentioned as they are, is greatly diminished. And so I would argue that those are two very positive things that folks can do throughout the year to help us in this fight against AIDS.
Thank you so much. That is absolutely perfect. And I think it's something that everyone can do. And this is a conversation we all can have and we all need to have, and not just today, and not just on commemorative days. José, thank you so much for joining us. Thank you for giving us your time on what is probably one of the busiest days for you. And most of all, thank you for the work that you've been doing.
Thank you very much. My honor.
I appreciate you. Well, everybody, that brings us to the end of another show. We have another great one coming up for you next week. Just as we sort of wrap up today, let's remember that today shouldn't be the only day that we are having this conversation, but let's all mark our calendars for July 21st, 2023, for Zero HIV Stigma Day, so we can have some more conversations again, too. But let's make this one of our year-round conversations. All the people who have gone before us certainly deserve to be remembered with action. We wrap up the exact same way every single week by reminding you to do 3 really important things: to run fast, laugh hard, and most of all, please be kind. It is a rough time of year for some people. While a lot of us are celebrating, it can be very difficult for a lot of people out there. Many people are suffering. Many people are also scared because of what is going on around us, and don't feel safe. So please check in with each other. Please see how people are doing. And if you need help, please remember getting help is not a sign of weakness. It's a sign of being smart and strong. Until next week, I will be preparing next week's show, which I think is going to be a really fascinating one that we're going to really have some fun with and have a great conversation. Please remember, if you need help before then, visit us at pflag.org to find your local chapter or to download some resources. We will see you next week on our next episode of Something to Talk About Live. Bye, everybody.